introduce and welcome Professor Lora Giangregorio from University of Waterloo, where she's a professor in the Department of Kinesiology and also a Schlegel researcher in mobility and aging. She leads a research program focused on increasing physical activity and reducing fracture risk. Her work has resulted, among other things, in physical activity recommendations for individuals with osteoporosis. She's a member of the Scientific Advisory Council for Osteoporosis Canada, and she's leading the effort to update clinical practice guidelines for the management of osteoporosis. Please join me in welcoming Dr. Giangregorio, and we look forward to your time.
I just want to say thank you very much for having me. And happy to answer questions along the way. If it's nice to have discussions. So if there's questions you have along the way, please feel free to stop me. I'm also a scientist with Toronto Rehab as well, and so I do some work here with a few colleagues. So I'd like to start with the main points, just in case you're having your pizza and you're starting to get tired and you need to have a little nap. The main conclusions I always start with, and for me, the main conclusions in this area are the hardest part when you're designing a clinical trial, whether it's a pilot study or a full multi-center trial. The hardest part is coming up with the right research question and plan associated with that question. So I would argue that you need to spend more time developing the research question and the plan than executing it. Sometimes you'll have an entire program of research before you get to that trial that really addresses the big problem that you want to address. And so you want to put some good thought into that. And in that sort of context, you want to use pilot studies appropriately. Sometimes we have an idea, we're like, okay, let's run a pilot. But what ends up happening is you spend a lot of time and resources running that pilot, and it doesn't actually answer the question you want it to answer, and it doesn't give you the information you need to move forward with your trial. So even with a pilot, think carefully about planning the trial for the pilot or the feasibility study so that you get the information that you want. Okay, so I'm going to go through some of those steps and give you some examples. I sort of have a number of questions that you can think about as you guide your process through that. So when we think about designing a clinical trial, and I'm talking in the context of clinical trials, you can use this for other types of research, but when we think of it, that we want to be able to answer, what do we know right now about the research in this area, or even in practice in this area? And what are the gaps, both in research and in practice? And why is a trial needed now? You should not write a clinical trial grant unless you can answer all of those questions. Why is a trial needed? Not just needed, but needed now, right? And so, Celine Youssef said this once at a workshop that I went to, and it really stuck with me. Ask an important question and answer it reliably. So do a good job of answering it. Often we'll design a study that tries to answer an important question, but we didn't put enough thought into the design so we can truly answer it reliably. So rather than spending a lot of time doing lots of little things, really think about how you can answer that important question. And sometimes that important question is around the burden of disease, around inactivity, around fractures as an outcome, diabetes, obesity, but also thinking about when you're thinking about how to address it, things like adherence, sustainability, cost effectiveness, those things tend to come up. So we start first with what is the big problem, and then we need to think about what is the type of research that is needed to answer that problem. Sometimes it's a randomized control trial to look at a therapy. Sometimes it's to look at, the benefits of the therapy. Sometimes it's to look at harms, or the balance of both. Sometimes it's to look at diagnosis, how to better diagnose something. And sometimes it's around prognosis. And there's many other types of questions. So you want to think, what type of research is needed to answer the big problem, right? And what is your research question around that big problem? But also, what is the type of research that is needed before you go to answer that big problem, or before you get to the clinical trial? And sometimes you need to do some pre-trial research projects to establish the need for the trial. Okay? So it's thinking about, before I get to this clinical trial that I'm dreaming of running, because I think it's really important, what other things do I need to establish to sort of lay the groundwork to show that it's really important and that I've done my homework? And so some of the things you might consider doing, one is a systematic review. And so I know that lots of people are doing systematic reviews, and it's almost become cliche. But if you apply to CHR, for example, to the Randomized Controlled Trials Committee, so I've sat on that committee, I've actually chaired the committee as well. If you apply to a grant for that committee, I can tell you there's a section. What systematic review have you done? So either you have to do one, or there has to be one recently done that you can refer to. But they're going to want to know that you're the expert in the field. So if you can establish that you know the field cold. So what has been done to date? What are the gaps? And how can your study address them? You will have to answer that question. You might also want to think about a study that addresses what is consumer or professional opinion around this big problem. So for example, what do primary care physicians think? What do specialists think? What do rehab professionals think? What do patients think if your problem is addressing patients? And that's becoming increasingly important, having a patient involved from the beginning and informing the research questions and the design, but even just broadly doing a survey and figuring out, what are current patient practices with this, related to this thing that I'm proposing, or what are professionals think. And if you can, you might want to try to establish that there's clinical equipoise, that there's genuine uncertainty about the answer to this question or about the way to address this problem. And that's why it's important. So if you can, for example, if you're proposing a new way of doing surgery, and let's say there's genuine uncertainty around clinicians' ideas of whether this surgery works or not. And some surgeons are doing it and some aren't. If you can establish that, that sets up the need for that clinical trial. Okay? So one example that we've used in the past to get to, and we've used this successfully to get a grant is, in people with osteoporosis, exercise is often recommended in guidelines. But there's a real uncertainty around the safety of certain types of exercise. So we think that exercise has benefits, but there's also potential for harm, particularly in people who are at high risk of fracture. So there's a genuine uncertainty here around exercise and how we can deliver it safely in this population. And that's why we need a trial, you see. So that's setting up that argument that there's genuine uncertainty. Then you can think about, is there pre-work or pilot studies that need to be done, or feasibility studies? So, for example, a needs assessment. What are the current exercise practices of people with osteoporosis? Or what are exercise professionals currently prescribing? Do they have genuine uncertainty? And then also, is it feasible to do what you plan to do? So if you want to run a clinical trial, can you recruit the people that you're interested in recruiting? Will they stay in your study? Will they adhere to your intervention? Can they even do the exercises you're proposing? Can they do the assessments that you want? Or are the machines that you need to work during your trial, I don't know what machines you use, are they going to work, and are they going to work in the time that you want? So one example is there was a study, I'm not going to mention which one, but a large multi-center study that was doing stuff related to aging, and there was a particular cognitive test that they were using a computer to do and administer on everyone. They ended up having to throw the data out because it had something to do with the processing speed of the computers were different, and so the test wasn't consistent across all the sites because they didn't pilot test it first. So thinking about those sorts of things. So if you're going to do a systematic review to identify gaps in future research, there are many resources at your fingertips. You can use Prisma, which helps you identify how to properly write up and design a systematic review and meta-analysis. The Cochrane Collaboration has a handbook online that's freely available and is very comprehensive. And also remember, if you are a budding researcher or early career, that you need to think about, your progress through, your academic progress, and this is an opportunity to publish some work while you're waiting to do your trial. So here's an example of a study that we did to get some information from patients. So we worked with Osteoporosis Canada. I didn't lead this study. Actually, the first author is a patient advocate that worked with us on this study. And so what we did is we did a survey of the Canadian Osteoporosis Patient Network. So this is a virtual network of people who are interested in managing osteoporosis. There's, I think, around 9,000 or 10,000 members virtually across Canada. And we had 1,100 people respond to our survey. And we asked a lot of questions around what are the things that you want to know about if we're going to do clinical practice guidelines? What are the questions that you have as a patient? What outcomes are important to you? And so I don't expect you to be able to read this, but I'm going to zoom in on the next slide on one section. But you look at, we actually got quite good distribution across Canada, of course, mostly in Ontario, but we did get some respondents from other provinces as well. And we asked a lot about about screening, pharmacotherapy, nutrition, just to get a sense of what their questions were. And if you zoom in, one of the questions I wanted to know the answer to was a very open-ended question. What questions do you have about the safety or effectiveness of exercise or safe performance of physical activities of leisure or daily living? Okay? And some of the things that came up a lot are around safety, right? So they know that exercise is effective. How can I exercise safely? And a lot of the times they were asking not about what exercises are safe for me to do, but they're like, I do this. I want to do this. Is that safe for me? So now we have to think about not saying throwing, this is the intervention I want you to do. You have to think, well, the patient actually wants to do this. So I need to know if it's safe for them. So the safety of yoga comes up over and over and over again with very little data. So now based on this work, we're actually doing a systematic review, pulling out case reports and everything we can know about the safety of yoga so that we can best advise patients, but also think about perhaps designing future trials around that. So safety, and then they wanted to know around the details of exercise prescription. How can I exercise effectively? How can I access safe and effective exercise? So this is implementation. So they're now giving us ideas for implementation science research questions, as well as the sort of efficacy questions. And then they listed a few outcomes that are important to them. Bone mineral density, fracture risk, balance and strength, pain came up, and quality of life. And so if we can translate that, you can see now we start to, some questions that you could potentially ask start to emerge. So what is the effect of yoga in people with osteoporosis? What types of exercise or physical activity are associated with
attention, attention, attention. Mark blue code, Q south, pool alarm. Attention, attention, attention. Mark code blue, Q south, pool alarm. Attention, attention, attention. Mark code blue, Q south, pool alarm.
And you can also think about the implementation science questions, and these often require a bit of a programmatic approach. So what are the barriers to exercise participation? What interventions address those barriers? Then designing your intervention. So even from an implementation science perspective, you still need to do that pre-work before you start to design the trial around your implementation intervention. If you are doing implementation work, there are still some examples of how you can do that. You can measure the gap from research to practice at the population level using questions that pull data from administrative or clinical databases. You can measure the gap at the organizational level, or even at the care provider patient level. And so these are there's some resources at the KT Clearinghouse if you're interested in some of this type of work. So some of the questions that might emerge: what do we know about the effects of exercise on X, Y, and Z health outcomes in people with vertebral fractures? Because this is a high-risk group, and they're concerned about safety. What are physicians or rehabilitation professionals' practices regarding exercise and osteoporosis? What questions do patients have? So that was one of the things that we addressed with our survey. And what outcomes are important to them? And then moving to the sort of questions that inform your pilot feasibility studies. If I'm going to do a clinical trial, can I recruit the population I'm interested in? Will they stay, and do they adhere? So we've mentioned that, but these are some of the examples now. We're narrowing down to our pre-work. So we've done our systematic review, we've done our patient-provider surveys. Now we've established why we need this trial right now, and then we have our need for the trial. So now we have to think about what is our primary research question. And what's really important here, if you're going to write a trial, a grant for a pilot study, is you have sort of to establish both the need for the larger trial and the need for your pilot. So you need to find space in that grant for both, because you really have to convince people that the larger trial is really important first. Then you have to say, but before we get there, we need to answer this pilot question. So you sort of have two phases, and therefore you have two research questions you have to work out. You first have to work out what is the research question for my larger trial. Then, what are the research questions for my pilot trial? Okay. So when we think about a clinical trial, we usually use the PICO format to come up with our questions. So that's population, intervention, comparator, outcome, time. Some people who use cohort type studies will use population exposure, comparator, outcome, time. So it's PECOT. And so instead of saying, for example, is exercise effective for osteoporosis, I might say, does resistance training program performed thrice weekly for 12 months result in increased proximal femur bone mineral density in postmenopausal women with osteoporosis compared to no intervention? You can envision the trial that I will do based on reading that question, right? So that's what you want your research question to look like. You want to make sure it has that sufficient detail, and that might be my larger trial. But then I might need to do a pilot before I get there, and then I have to think about the wording for my pilot research questions. So your grant proposal will have a rationale for that larger trial and the research question for the larger trial. But then you will also have a rationale for your pilot study and the research questions for your pilot study. So before you move to the trial, you need to think, do I need a proof of concept study, which is generally a clinical trial carried out to determine if a treatment is biologically active or inactive, and it's usually based on surrogate markers. There's also the language around phase 1 and 2 studies, so these are usually done before a large clinical trial, and they're usually studies of safety, dose levels, and responsiveness. And sometimes you can do a run-in phase of a phase 3 trial. This can be a pilot study, where you look at the compliance with a complex treatment procedure at the participating centers. Okay? And a pilot study might be an example of that. And so if we look at some definitions for pilot or feasibility studies, there's lots of different ones. A pilot study is a small-scale test with the methods and procedures to be used on a larger scale. A small-scale investigation designed to test the feasibility of methods and procedures for later use on a large scale, or to search for possible effects and associations that may be worth following up, like a dose response. Some have argued that pilot and feasibility study are two different things. I'm not sure I'm in that camp, but I can tell you what those that argue this point use as that distinction. So they would argue that a pilot study is a replica of your larger trial. So essentially, you are doing a small version exactly of the trial you propose to run, to test how well the processes work together. So a pilot trial would be a randomized control trial, but it has pilot objectives. So it often evaluates the main trial processes. It has the exact same protocol as the main trial and will assess the main trial primary outcome. Whereas a feasibility study can be a randomized trial, and it can be a replica, but it can also be just to gather information to formulate the protocol for the main study. So you might do a study just looking, let's say you wanted to recruit people with spinal cord injury, and you wanted people with incomplete spinal cord injuries. You need to know how many people would be potentially eligible. So you might do a feasibility study just doing screening around, how many people in your center and in all the other centers that you're interested in recruiting from might be potentially eligible for your trial, just as a run-in before you actually design your study. Right? Another example might be timelines for study visits. So you might not necessarily need to do the whole RCT just to figure out how long the study visits will happen. So this is feasibility data that you're collecting. Or adherence of the team to the protocol. So you might say, okay, I want to know how good the fidelity will be. If I'm going to do an exercise intervention and I want 3 centers to deliver it, I want to look at how well the exercise professionals deliver it, and do they have good fidelity to my protocol. Now, what are the things that influence fidelity? Right? That might be, you don't need to do an RCT to do that. Right? So there might be different things you would answer with a feasibility study than you would answer with a pilot study. But you can also have a pilot study that is also a feasibility study. Does that make sense? So that's how people argue the difference. I don't really think we need to spend time doing that. Okay, so here's some reasons you might do a pilot study. So what is recruitment and retention problems? This is the major reason I've seen for pilot studies is, can we actually recruit people? Do they stay in the study? What are the characteristics of those included versus those that are not included? What are the characteristics of those that are lost to follow-up? How can we improve adherence? What are the non-compliance rates? Ambiguous situations. So one of the things we discovered when we did our pilot study was that, so for example, we were concerned that if people had cognitive impairment, that they wouldn't be able to do our exercise intervention. They wouldn't be able to follow instructions. However, what criteria do you use to identify people that have impaired cognition so that they can't, like, what level of impaired cognition dictates whether you can do the exercise intervention or not? There's no criteria, or even actually whether or not you can consent to being in a study, right? So that's something that was a bit ambiguous. So we started with a process of using this particular screening tool that has 2 questions to assess a person's, it's called the mini-cog. We use the mini-cog to screen people. But then what ended up happening was people were failing the mini-cog, and then we had to go back to their physician and say, do you think this person can be in a study? Or we had to do something with that information, and we're not diagnosing anything. So then we were put in a bit of a funny position, right? And the reality was some of the people who failed, could probably still be in the study. One, the physician decided that they shouldn't be after follow-up testing, but it created a bit of a problem. And so what we realized is that it wasn't a great way. So we actually adjusted our eligibility criteria during the pilot because we learned this information. And we decided that a better way to assess it was to go through the consent process with them and let them read the consent form, and then ask them to explain to us in their own words what we were asking them to do. And if they could do that, then we felt that they could understand instructions sufficiently that they could participate in the study. So that's what we then changed our eligibility criteria to, and that was something we learned during the pilot study, during the screening. The other thing you can learn is the eligibility sufficient or too restrictive? So this was something else we learned is, originally we had the criteria they couldn't.
Attention. Mark code blue, all clear. Attention. Mark code blue, all clear. Attention. Mark code blue, all clear.
So we had a criterion of they couldn't have cancer, a history of cancer. And then we realized that it was a bit too restrictive because there were people who had like a basal cell carcinoma on their nose, and there's no reason why they couldn't participate in the study. And then there was, some people who had cancer 10, 15 years ago and were in remission. And why shouldn't they be in the study? And so we then, again, adjusted our criteria because we learned that, there's certain indications where a person shouldn't be in the study and others. So it helped us refine our criteria. Also looking at study questionnaires. So if you can test out your questionnaires and see do people understand them. Do they complete them? Are there some that are too complicated? Time and resource problems. So how long does some of these processes take? Will study participants overload phone lines, right? So this was these are things, real life problems that you need to test out. And there are things that you can test out in a pilot study. There's a number of others. So I mentioned the machinery problems. So what happens if it breaks down? Do you have backups? Those sorts of things. Data management problems. Does your data show too much or too little variability? So there's a number of things, and I'm not going to go through all of them, but just thinking about, there's so many different problems, and you don't want to invest the resources to do this large clinical trial and not have sussed out these problems. And in fact, a reviewer will often identify these problems in your grant proposal, so you want to make sure you've addressed all of these things. So another way to think about it is when you're writing your grant, ask yourself all these questions. And then in your grant proposal, make clear that you've already thought about it and this is what you've done to address it, right? You've collected, data on information on how many people are in your center, etc. Safety is another one, and responsiveness to, you can use surrogate markers to measure responsiveness. That would be another example. So here I've compiled some examples from a study that my PhD student, or a paper that my PhD student wrote about pilot studies for exercise and rehabilitation research. So this is published in the journal Pilot Feasibility Studies. And we did it according to population intervention comparator outcome and time. And so some of the reasons you might do a pilot study in the rehab or exercise realm, one is recruitment. So can you recruit people? And not just like, are there enough people with this condition? But are there enough people who agree to participate in your study and agree to be randomized? So here's the thing with exercise and rehab research, is that they're not blind to group allocation most often, right? It's very difficult to blind people in exercise and rehab research. They know if they're getting the intervention or not, unless you have some cool way of doing a placebo, or if you have another way of using deception, right? Saying, oh, we're testing the difference between these two interventions, but really you know one of them doesn't work. So there's some ways to do it, but most often these studies, there's not blinding. And the problem with that, people want the intervention, right? So as soon as they find out they're going to be randomized, that may actually cause them pause, and they may not want to be in the study anymore, especially if they can go and get that intervention somewhere else, which is often true for exercise and rehabilitation interventions, right? You can often find a clinic or a personal trainer that will give you the intervention, and if you can pay for it, then you may not sign up for the study. And so this is something you really need to identify in a pilot study, is can you actually get people to agree to participate and agree to be randomized and not drop out after they've been randomized to control, right? Is it safe for them to participate? So this is something that, we get questioned a lot in the osteoporosis world, is this intervention safe for these folks? Are they not doing similar exercise? Here's a huge problem. Who signs up for people for exercise studies? People who are interested in exercise. What are the odds that they're already not exercising, right? So often what you get is people who are already exercising and are looking to add something more, looking for the newest and best intervention, right? But unfortunately, they're not eligible for your study because they're not enough, right? So you have to figure out what are the active components of my intervention. So maybe it's not that you recruit people who are not exercising. Maybe if your intervention is resistance training at X intensity, then you just you recruit people who are not already doing resistance training at X intensity. So they could be walking 3 times a week, they could be doing yoga, but this actually came up because sometimes it's not entirely clear. So what if they say, well, I'm going to an exercise class and sometimes we do resistance exercise, right? Are they eligible? So these are the things you'll learn in a pilot study when you start screening people and you realize how difficult it is to figure out, especially in this particular arena. From the intervention perspective, you want to look at participant or provider fidelity. Are they following your instructions? Is the exercise instructor teaching the intervention, doing what they're supposed to do? And this is particularly problematic with a multi-center trial. If you have one physio delivering the intervention one way, and one physio delivering the intervention another way, or they're doing different intensities, or one is a really motivated person and one is not, it can be very challenging. So you need to know, are they actually delivering the intervention with good fidelity? Do they understand the intervention instructions that you're giving them? Is there a way to standardize the training for the people delivering the intervention? And does that standardized training work to get good fidelity, right? You could look at dosing, right? What dose should I offer this at? How frequent? I need to find a good balance between how often they're willing to do this exercise and how much I need for it to be effective, right? So I might want them to do it 5 times a week. It may not be effective at 2 or less times a week, and they're willing to do it 3 times a week. So I got to find that out. So maybe I try throwing 5 times a week and then see how often they actually do it, and that might help me understand what would be realistic in a larger trial. Adherence, both difficult to measure, but also really important. And also for exercise trials, very challenging to maintain long term. So it's one thing to maintain, if your trial is going to be a year, you might need to do a pilot trial to see what the adherence is at 12 months before you go on to your larger trial. Because it's one thing to get people to adhere for a month, for 2 months, right? Everybody's working out now, it's January, right? My gym is packed, right? But is it going to be packed in December? We need to know that, right? So what is and even thinking about how to measure adherence. So what we discovered in our study was, our pilot study was, the way we chose to measure adherence was problematic. Because we actually had people fill out a monthly log, like a calendar, and they just had to check off, did I do it today? And we had people not bringing in calendars. We had people oh, I'm going to Florida for 4 months and I'm not going to be able to do my calendars because I just don't want to, or because I don't have, because we give them Canadian postage, right? And so we had to send people like American stamps so that they can mail in their calendars. Some people chose not to. The missing, how do you deal with the missing data related to adherence? There's lots of issues that ended up coming up. We could try to objectively measure adherence by putting accelerometers on them, and in fact we did that. The problem is if your intervention is resistance exercises, accelerometers don't measure that all that well, right? So you have to think, can I objectively measure adherence, and what is the best way to do that? And you can even use a pilot or feasibility study to try to answer that question, if this is a really important outcome to you. The comparator, you're going to get post-randomization dropout if you don't do something to retain those people. So one of your pilot questions might be, how many people drop out after randomization? How do I retain them? So things that we found work really well are sending newsletters and continuous communication and Christmas cards. We decided we were going to give them the intervention at the end of the study, so that kept some of them in. You may also want to look at contamination. So one of the things we did, which was different, was we actually measured adherence in the control group. We actually asked both the exercises and the control, did you do any strength exercises today? Did you do any aerobic exercises, etc.? And what we found was that 20% of our control group reported doing some resistance training exercises. So there was evidence of contamination, and most studies don't measure this. They assume the control group is not going to do anything. But that is definitely untrue when we look at our data. And that could potentially create a problem when you're looking for efficacy, right? So you may think about an attention control or a deception control, and whether or not it actually works well. That could be another question you can answer in a pilot study. And finally, the outcome and the time. So participant acceptability of your intervention, or the outcomes, are they important to them? Are they satisfied with your intervention? Do the performance-based outcomes work well? So we had a number of outcomes that we chose that we couldn't actually get data. So we did a 5 times sit to stand test, and a substantial number of our participants couldn't do it at baseline because they had mobility impairments. And so we realized that's not a good outcome to use in this population. Or we had some outcomes that had ceiling effects in our population. So you can actually test out those things. You can look at the psychometric properties of some of the outcomes that you're interested in a pilot study. Okay? And finally, retention. Do they stay in the study? So, do a pilot to decide if you really want to commit to a large trial, to convince funders that you have what it takes to run the large trial, and to work out any bugs that you need to work out before you run the trial. I saw this quote once and I thought it applied well. It was a World War II pilot, and he said, never fly the A model of anything. And that applies, I think, to clinical trials, right? You want to make sure you know what you're doing. If you're going to invest hundreds and thousands or $1 million in doing a clinical trial, you need to work out these issues. So what are the key features of a pilot trial? So one, the primary question pertains to feasibility, okay? Or evaluating aspects of the trial. And so that might be, is it feasible for me to recruit people with vertebral fractures to participate in a randomized controlled trial of exercise 3 times a week over 1 year, something like that. Another thing that's really important and that you need to have are criteria for success. So if you're asking, is it feasible, you need to say, what is feasible? What are my criteria for success? And you need to say that a priori, right? Because it's very easy to allow your own biases. Oh, well, we only recruited, 50% of the target, but, it is feasible because really we only need that many. Or you can make those reasons up afterwards, right? So a priori, you should define what is your criteria for success in order for you to be objective in making your inferences later, right? So you need criteria for success. Any inferences you plan to make about efficacy are exploratory or hypothesis generated, because your trial is not designed to answer those questions. And you will need to have the rationale for your future definitive trial, which I've already mentioned. I'll also point out that there is now a journal called Pilot Feasibility Studies that explicitly publishes this type of research. So you can look to that if you're looking to publish. Some things you might need to think about is how similar does it need to be to the planned trial? What is your target population? Sample size for a pilot trial is tricky. So you're basically piloting it to answer your pilot feasibility question, right? So it needs to be large enough to provide useful information about the aspects being assessed. So one way to think about that is, let's say you need to recruit 200 people for your larger trial, and you need a recruitment rate of 5 people per month. You might do a pilot study over 6 months and say, the criteria for success are that I can recruit 5 people per month over a 6-month period. So if I can do that in my 6-month trial, hopefully I can be able to do that for my larger trial, right? So that's how you sort of work backwards and come up with your sample size. Okay? So you can also use other approaches. There's some references here I can point you to if you're interested. There's a 95% confidence interval approach. But just even thinking pragmatically is come up with numbers that make sense, right? So another one is adherence. You want to look at the feasibility of adherence to an exercise intervention over 1 year. What adherence level do you need to convince yourself that you've actually given them something that is enough of a dose, right? And so when we did it, we said, okay, well, we think that over a year, if the adherence is 65% or more, and we based that on previous studies, because these other studies have been done and shown effects in surrogate outcomes with adherence rate of that level or around that level. So we kind of had a justification based on our previous research, based on the systematic review that we did, and also based on some other information. So we pulled together a few references that supported that we wanted, we would say it was feasible if the adherence was 65% or more over a 1 year period. And then, again, your criteria of success need to be balanced between what is ideal and what is realistic. Importantly, when you make your conclusions, so now you have your data, you don't necessarily have to say it's not feasible or it is. You can say it's not feasible, it's feasible with modification or monitoring, or it's feasible as is. So there is some leeway there, but it is important to have the criteria for success. And some people will actually do their pilot within the context of the full trial. So they'll start their pilot, and if things are going well, they'll actually roll it into the larger trial as well. And there are methodologies to use if you want to do that. So do a pilot study if you want to inform a larger trial, if you have clear feasibility objectives and a prior criteria for success, and clear analytic plans. Do not do a pilot study because you don't have enough funding to answer the question you really want to answer, because it's quick and easy to do, because it's similar or slightly larger than another trial, or if you plan to make inferences about efficacy. Okay? So some of the considerations I've already mentioned, but one of the things we need to think about is how can we better blind our participants and providers? Is there new ways we can do this? So can we use deception? Can we say, oh, well, we're going to compare 2 interventions, but then you design a control intervention that doesn't have the active ingredients of your intervention, right? So people think they're getting an intervention, but they're not, right? It's tricky. You have to mess with your ethics board a little bit, but not mess with them, but you have to provide a convincing rationale for why you want to do that. And so one example might be if I want to look at bone density as an outcome, and I'm interested in impact exercise, and let's say I design a jumping intervention, right? I could argue that there are meta-analyses that show that walking does not have, or maybe Tai Chi or low weights doesn't have an impact on bone mineral density at the sites that I'm interested in. So I'm going to compare walking to my jumping intervention, because I know walking is not effective, and I can show you a meta-analysis that proves it. So I'm going to compare this, and I'm going to tell my participants that I'm comparing these 2 interventions, right? So that might be one way to do it, as an example. You can also have an attention control. So that's what we did in our pilot study. We actually had physios. So ours was physios doing home visits, and they would teach people exercise on home visits. And so the physios still visited people, but they did education around other health topics. And then we gave them the intervention at the end. So that's how they got an attention control. It's important to think about reporting the intervention details. So rehab research gets knocked on this a lot, but they don't sufficiently report the frequency, intensity, time, type, provider qualifications, the training that was provided to them, any framework that was used to deliver the intervention, the actual exercises that were used. This is very problematic. People don't report that. Or the therapeutic goals of the intervention. Right? So these are some things to think about. And you can actually use the TIGER and the consort reporting guidelines for non-pharmacological intervention. So the consort now has reporting guidelines for this, so I highly recommend that you use those if you're thinking about designing a clinical trial in this space. You can publish them, results. You want to share this feasibility information. It also avoids duplication of efforts if your colleagues are doing similar work. They're not, these pilot studies are not usually powered to detect differences, so you really should make strong inferences about efficacy. So focusing on feasibility in your reporting. Now, it doesn't mean you can't report. So for example, for one of our pilot studies, we reported the feasibility data, and then we reported the physical function outcomes, but we were very clear that these were secondary outcomes from a pilot where the primary objective was feasibility, and so they are exploratory. But we had 140 people and we had good data, so we might as well share that data with the world as well, but being clear and transparent that this was not the primary outcome.
Just back to something you said a few minutes ago when you said that in terms of your control, you provided the intervention later.
Yeah.
Yeah. So did you provide the intervention only once you knew it actually was effective, or did you give it regardless?
We gave it, so the question, just so I'm repeating it for those who are listening, was if we give the intervention to our tension control at the end, did we give it regardless, or did we give it only if we knew it was effective? We had promised them that we'd give them something at the end, so we gave everybody something at the end. We didn't give them the exact same thing because it was too resource intensive, so what we did was they got a 2-hour visit with the physio assessed them and gave them a home exercise program and showed them how to do all the exercises and gave them pictures of the exercises, and they did one follow-up over the phone.
So that was promised up front in the information.
Correct.
And so on. If you are in the control group,
You will get this. Yep. So, you can actually have one trial be a program of research, if you plan. So you can do systematic reviews, needs assessments, surveys of consumer provider opinion, then you can do the pilot trial to demonstrate feasibility or proof of concept, then you can do your full trial, then you can report on the secondary outcomes of your full trial, you can report on the patient satisfaction, then you can have a KT plan where you design studies to get your research put into practice and actually do a series of studies to do that as well. So you can spend 10 years doing one clinical trial if you really want to. So it's thinking about how to do this, and that's why I said right up front, is spend more time thinking about the plan. If you can write this in a grant and say, this is what I'm thinking. I'm going to do this, then I'm going to do this, then I'm going to do this, then I'm going to do this, and I envision that I'm going to work to design a KT plan and then do this to get it into practice. If the reviewer can see how your work will actually change practice 10 years down the road, you're much more likely to get funding than if you're just saying, well, I think I might want to do this pilot because I have this really cool idea. Right? So some of the studies, some of the things we learned in one of our field trials was about recruitment barriers. So we actually found it very, very difficult to recruit our population. So our population was women over the age of 65 with one or more osteoporotic vertebral fractures, already hard to recruit. Okay? Then there were issues around willingness to be randomized. So there were people who really wanted to be in the study until they found out they could be randomized to control. So there's some people who never want to be in a study or don't want to exercise. So we've already written off those people. Then there's people who really want to exercise and they're already exercising. So we've written off those people. Then there's people who really want it, they're not exercising at the levels that they're eligible for our study, but they're not willing to be randomized to control. So therefore, they're going to go pay a physio to do the intervention, or go to the free community exercise class. So we were working with this very small group of people ambivalent enough about being randomized to control, but yet willing to be in the study and exercise. Not a lot of those people, right? So we discovered that it was really, really challenging in this group of people to recruit people. We managed to do it. We recruited 141 people, but it took almost twice as long as we thought. So that was something we learned. We learned that language or personal barriers were a huge barrier. So people not being able to speak English sufficiently to interact with the physio. This occurred mainly in larger cities. That ruled a lot of people out. And competing programs. So Toronto actually was one of the worst places to recruit because there's other studies going on, because there's lots of community programs available and lots of resources here. So they could just go down the street to get a program, so they didn't need to be in our city. Where we did really well was in smaller communities where there weren't so much stuff. And there's one physician, and that physician was super keen about our study, so they were referring everybody, right? Facilitators, enthusiastic recruiters. So if you get a research nurse or a coordinator who's super engaging, or you get a physician or whoever's referring your patients really excited about your study, actual clinics that deal specifically with your population. Some studies actually had a participant pool where they had a group of people who were interested in learning more about research that they could contact. Those are really good facilitators. We made a trade-off. We decided to use a home exercise intervention because it's more practical and more cost-effective. And I can tell you that I probably will never do a home exercise intervention again. And the reason is I don't honestly believe that 5 visits over the course of a few months is enough to figure out what exercises a person should do, to get them doing it with proper form, and to adequately progress their exercise program. And I think that you have this balance where it's more convenient for people, but I don't think necessarily you're getting a sufficient dose, and the ability to get them to adhere to the intervention is not there. So I really feel that you need a bit, even if you do a bit more comprehensive at the start end and then transition them to a home program, it's probably better than trying to do mostly home program with internet supervision. So I think with a center-based, so I guess it depends on your research question. If you're truly asking about efficacy, you might need a bit more control on the delivery of the dose of the intervention. If you are doing a pragmatic trial, where you're more interested in, does this work in the real world in the context that I can offer exercise, and the only context you have is home exercise, then perhaps you need to go that route. So again, thinking back to your research question, are you asking about efficacy or are you asking about effectiveness? So 2 different things, right? So I'll come back to the main points. The hardest part is coming up with the research question and the plan associated from start to finish for your clinical trial. And you may need to spend more time developing the plan around the importance of the trial, the pre-work that you need to do, the design of your trial, how you're going to change your trial based on the information you've gathered, and eventually do your trial and translate it to practice. And you may need to actually spend a lot of time developing that plan to do something that's actually going to make a difference. Use pilot studies appropriately. Don't just do them because you think they're going to be quick and fast to do. I guarantee that will be a disaster. And understand what you're going to do with the findings. So at this point, I'll open it up for questions. I do want to thank you for having me here today, and happy to answer any questions that you have.
Hi.
Yes.
So I have a question about that diagram that you showed about writing the grant, start with the plan and then feasibility study, trial and KT and everything. But that's like a long-term plan, that can expand up to, as you said, 10 years.
Yeah.
But these grants are normally 2 years, 3 years. So how we can squeeze all these things, together and still make a case?
Multiple grants.
Multiple grants.
Yeah. So you need to figure out what resources do I have available, and what can I do with those resources to move me towards there. And sometimes you have to take chances, and you have to look for opportunities. So maybe you get a small little pot of money to do needs assessment or a systematic review, and then another small little pot of money to do this. Or you know what, sometimes you do it on a shoestring. You know what, I'm going to do some of this work myself because I need to gather this information. Or how can I get some in-kind resources to support doing this survey? And how can I work with people? And sometimes that involves partnerships, getting stakeholders that are interested in the work that you want to do, and they work with you. So we work with Osteoporosis Canada. They have the Canadian Osteoporosis Patient Network. It doesn't cost us anything to send a survey. We design the survey, we put it out there, right? And then we can use that information to then get a grant to do something else, to then do something else. So there's no way I would suggest putting all of that in one grant. I think it's about using the resources you have to do as much of it as you can, right? In an ideal world, it would be a lot of money to do all of it, but sometimes you just have to be creative. Yeah. Yes.
Thanks, Laura. That was really great. You briefly mentioned internal pilot studies, so rolling the pilot study into the larger trial.
Yeah.
Could you talk a little bit more about the right and wrong ways to be able to do that?
Yeah, I have to say I've never done it, so I don't have personal experience, and I know that there's limited ability to do that because you really then have to. You can do it when your pilot went so well that you're not going to change the study design that much, and that rarely happens, right? So I don't know a lot of people who have done that, but if you have enough consistency between the pilot trial and the full trial, then you could argue that you could do that. Even things like changing your randomization, right? Sometimes if you add more centers in your or you're stratifying by different variables, that can all of a sudden change things. So I think if the outcomes stay the same, the timelines stay the same, and most of the critical protocol elements stay the same, then you can do that. But I don't know of anyone who's done it, put it that way. So to see how, and I think it's something where a lot of people who do that will sort of plan it into the grant proposal. So they'll say, I'm going to do a run-in phase where I'm going to do X, Y, and Z, just make sure we've got this. And they'll have a priori criteria where they can say, I'm going to use these, I'm going to roll it in if we do X, Y, and Z. Otherwise, we're going to then recruit and start a new randomization. But it's usually part of the same grant as opposed to being two separate grants. But a lot of people will just apply for the money to do just the pilot. Yeah.
Question online, they'd like you to repeat the last question, please.
Oh, sorry. The last question was, how do you roll a pilot into a full trial? I should speak to the microphone. How do you roll a pilot into a full trial? Yeah. And so I think that, like I said, I've never done it, so I wouldn't call myself an expert on doing that. But what I've read is that there's some kind of rules around it, and a lot of that has to do with the consistency of the protocol and sort of probably pre-planning it. Right? Not doing it after the fact, but pre-planning the run-in phase to say, okay, we're going to do a run-in phase. It's going to have these rules attached to the roll-in, and then we're going to do it. Yeah. Yes.
I was disappointed that you weren't going to do anything more with home exercise.
No.
I thought that was a rather negative thing to project when the future is clearly looking after people at home and preventing things at home. So perhaps you could revise that advice.
You're right,
and
I should revise
suggest some
that. It was
alternative
very
strategy.
flippant. It was very flippant. It was very frustrating. So what I would say is, I think that we need better ways to supervise people at home.
Positive.
Yeah, that's I would say. So it's not the home exercise that I wouldn't do. It's the traditional model. The traditional model of home care that we see now in hip fractures and this kind of group is they get maybe 4 visits over a 2-month period or something like that, right? That's not a lot of time. It's not enough time to help someone change their behavior, to develop habits. It's not enough time to see what they're capable of and progress them. And so the model of delivery where unfortunately we're at with our current, and the reason why we designed our trial that way was because we were able to pitch through years. Look, this is what we have access to in home care. People who have a hip fracture get this much. So maybe people with vertebral fractures, we can do the same thing, right? And so we're going to test that model in our pilot. And what we found was that the adherence didn't, as soon as the person stopped visiting them, the adherence went like, we actually can see that on the picture. And then you'd have another home visit 6 months later and it would go back up again and then it would go back down, right? So I think there need better ways, even if it's using technology or other ways to supervise or engage with people. If we can do a better job of supervising people at home, even intermittently, I think it would be better.
So I think that's one of the big challenges we face with half a room full of people doing technology is how do we get people to be more active in an effective and safe, supervised way at home.
Yeah.
Right.
I think what I see in the future is that you're going to have a time where you see them in person, and that time is to spend that time developing a relationship, getting a sense of what they're physically capable of doing, and cueing them properly, because it's really hard to do that if you see someone remotely. Like, I can give someone a picture of a squat, I can describe how to do it, but unless I see them do it and figure out what it is, because everybody does it wrong differently. So unless I can see what they're doing wrong and cue them, I can't get them doing it properly. And so I think that's the challenge, is a few visits in person, and then you could follow up with some technology-supported follow-up that mainly focuses on behavior change and progressing the intensity. Once you've got them doing it properly, they know what they're doing, that's where I would go. Yeah. Thank you for that, because you're right, it was a flippant and unpositive, not positive comment. Okay.
So I know this talk wasn't about this, but what did you find eventually? What was the outcome of yours?
So once we got people in the trial, our retention was excellent. We had a 91% retention rate, which I think I was quite pleased with. The adherence met the criteria for 65%, but just barely. And that was largely because the adherence at the start was quite good, and at the end was not so good, right? So it balanced out. And we found that recruitment, it took us, we got people in the trial, but it took us a really long time. So I would expand the inclusion criteria, there are ways to do that. And then in terms of actual outcomes, in terms of, I don't think that the dose of exercise is sufficient. We did see some improvement in mobility outcomes, but it was very small. And so again, I think you need a more intense intervention if you actually want to change.
Can I take my turn to be negative?
Yeah.
You know, I've seen so many, and this is not a comment on your intervention,
No.
but one sees so many rehab exercise interventions that prove to be successful. They almost always get a better result. And then at the end, the exercise program collapses and disappears because it only worked while there was an enthusiastic research assistant running the exercise program.
That's right.
And when the grant finishes, nothing else happens.
Because they don't have the KT plan at the end.
They don't have anything at the end, and nothing ever comes of it. I mean, there's been studies over and over and over in this province, and each time they're successful, and then nothing happens, right?
And I think that's where we need to maybe start moving away from efficacy and towards effectiveness, and also choosing trials that pragmatically assess, does this work in the real world? When we use the constraints of the real world, and also the people in the real world. Because what you see in exercise trials is really healthy people who have no comorbidities and are low risk, right? That's not the real world. Like, so we did a pilot, it wasn't even a pilot, I was just kind of testing something I wanted to work with. And I explicitly recruited complicated people. And we wanted to test out this, strength training intervention. And I had a woman, she was very overweight, she had just had a knee replacement, and her other knee was bone on bone, she had osteoporosis and spinal stenosis. So she would be excluded from any exercise trial I've ever seen. Right? And I'm like, all right, we're going to figure out how to do this. And, she could do the program, and she could be in the study with modification. So I think we also need to be creative with our exercise interventions in that you almost need, rather than this is the exercise intervention, you need, this is the framework for the exercise intervention, and here's the levels of ability, and here's what I'm going to do if the person has this, this, and this condition, so that we can actually design it already for the real world, as opposed to doing this exercise intervention that's only good for people with these criteria, right? So that's another issue I think that we face, is around how do you translate it to the real world? So people present with multiple health conditions. So an exercise program for osteoporosis is not going to work in the real world. Yeah. Yes?
Are there strategies for retention? Do you get better retention in groups as opposed to one-on-one?
So are there strategies for retention? Do you get better in groups than one-on-one? I think that some people really enjoy group exercise and some people do not. So I think you need a balance. I don't think requiring a group exercise program is good for sustainability, because as you mentioned, it's hard to get funding to have that going on. So I think you need a hybrid. I think from a resource perspective, it's cheaper to bring people together in groups, and maybe small groups would probably be a good thing. And also, some people really find working with others motivating. So we did find that this summer when we were pilot testing the group I told you about, is that the two ladies really, they were cheering each other on. The one lady's like, I just want to learn how to do this so I can do it at home. I don't want to come back. And she's actually the one who's been the most successful in follow-up, because she's figured it out, she knows what she needs to do. She and I talked about strategies for her to do at home. She had a plan, and she did it. Whereas the other two did really well when they were together, egging each other on. But as soon as they left the program and didn't kind of have a plan for doing that in the future, they struggled, right? So I think if you're going to have a long-term program, people do like the group, and it might be a good way to engage people to participate. But the planning on how you're going to do it later is really, really important. Yeah, so we found strategies that helped with retention, frequent contact, whether it's in person or over the phone. We sent them Christmas and birthday cards in our study, and they loved it, I got thank you cards for the birthday cards, right? Because they were like, thank you, it really meant a lot that you remembered my birthday. And they really thought, and I wrote them personally, so they really were quite pleased that they got a thank you or a birthday card.
As long as they were still doing their exercises.
Yeah, well, and they did say that, those types of things. And so we did get a lot of positive feedback. We've also done some work with the KT stuff, and I think a lot of that too is around broad population-based strategies to help people find the information. So I'll give you a good example. We did the guidelines on osteoporosis, and we developed a KT strategy where we actually did a lot of work talking to people about what their barriers were, and then we turned those barriers into stories. And so we had videos that told a person's story, and then how they overcame their barriers, and then this is what their exercise program looked like. And we did several of those, so it shows that not every exercise program is the same. People of different risk levels do different types of exercise, and that's okay. And here's a next step for you, right? And I would get emails from people in Florida saying, I came across, you know, your website, and now I know this is what I need to do to become more active. So I think using media and those types of things to kind of communicate research messages is one way to reach a broader group of people as well. Any other questions? Again, thanks for having me. I really enjoyed being here, and I'm happy to